Okay, good afternoon. Welcome back to Medical Grand Round. I'm Bob Wachter, chair of the department. For those that are here, the food is a little delayed. When it comes in, it will be distributed to your rows. So hang on tight. For those watching remotely, you can eat as you wish. Very excited about today's Grand Rounds. The topic is ethical cases and conundrums in medicine. We have many of them. We sometimes grapple with them as individual clinicians and teams, but it's also incredibly useful to have an ethics committee at the institution that can come in and give us wise counsel and often mediate to gather information from a lot of people and has real expertise helping us solve or manage these very challenging situations. And we're very lucky to have in our department the chair of the UCSF Medical Ethics Committee. It's Sirisha Narayana, who is professor of medicine at UCSF Health, lives in the Division of Hospital Medicine, and is chair of the Ethics Committee. Word about Sirisha: she went to Stanford undergrad, Northwestern for her MD, Seattle, University of Washington for residency and chief residency. I was lucky enough to recruit her to the division a while back and knew that she would become a star, and she has done that. She's won a number of teaching awards. She's a member of the Academy of Medical Educators. In fact, she's the Academy chair for medical education for the next couple of years, and has been a really wonderful contributor to our community. So Sirisha is going to run through a few cases that are emblematic of the kinds of cases we see in a complex academic setting like this, and then we'll have plenty of time for discussion. Sirisha.
Thank you, Bob. Hi, everyone. Thanks for being here. So I adjust the mic here. So excited to see so many of you in the audience and to know that there are many of you on Zoom. And like Bob said, I'm going to be talking to you all about complex ethical cases and conundrums in medicine. I don't have any disclosures, but I do have a disclaimer. So as Bob alluded to, this talk is really going to focus on the ethics at the bedside, the kind of ethical questions and distressing situations that we take home with us after you try to create a complex management plan as an outpatient or consulting on a really difficult case in the hospital. As much as I want to talk about larger societal ethical issues, Supreme Court cases, reproductive justice, I love talking about all of that. And that is actually not the focus of this talk. So that can be a separate discussion. I will be bringing up some more policy issues and things that are happening societally in the context of how they relate to our patients. So just as a heads up for what you might expect. Now, most ethics talks can leave you more disgruntled than you clearly see things as black and white. And if that is how you leave this talk, I will have met my goal. I want you to think. I want us to feel a little angsty inside, because that is often how so many of these cases actually present. But what I hope to do is first apply a framework of ethical reasoning to a few cases. I'll go through 3 cases that are all real, all within the Department of Medicine that were brought to us on ethics by many of you. And then reflect on those cases in patient care and how moral distress can actually impact our experience as clinicians. And so hopefully by the end of the talk, we would have gone through that. Okay, so just to give a little bit of the lay of the land, as Bob mentioned, I chair the Ethics Committee and I run the Ethics Consult Service for UCSF Health, which means we deal with clinical ethics issues at Parnassus, Mount Zion, Mission Bay, and all our ambulatory clinics. San Francisco General has their own ethics committee. The VA has their own ethics committee. St. Francis and St. Mary's have their own ethics committee. We'll see if that changes, I guess. But currently, that's kind of how we're at right now. So I wanted to give you a sense of how many consults we have and where they're coming from. So this was data I extracted a while back. So between May of 2024 and May of 2025, we had about 80 consultations. 2 of them were from the ambulatory side, and about 7 were from patients or families. And the rest are all from the inpatient side, from hospitals. The percentages may be a little bit small to see here, but this light blue is adult medicine. So hospital medicine is calling us the most with complex clinical issues, followed by cardiology, then by the medical ICU, and then a smattering from LTU and the inpatient hemonc service or CRI service. We do have a lot of unique consults from pediatrics and OBGYN, but I say this and offer you this data because this is largely where most of our time is spent, is with all of you, and why it's so relevant to much of what we do. Okay, so just some rudimentary foundational work here. Mostly it helps us have a shared vocabulary when we actually talk about these cases. So most of us, when we went to school at some point in our schooling, whether it was medical school or before, learned about principalism. So in the four main principles that were written about by Beecham and Childress back in the 70s and then evolved over time were beneficence, so do good, non-maleficence, do no harm, autonomy, which was really written as respect for persons initially, and then justice. So justice sometimes gets prescribed as distributive justice, but really the way we should think about it largely is fairness. How do I know I'm being fair in the way I offer and deliver care? So this is a very rudimentary foundational framework in which to think about complex cases. And it's totally acceptable to use this as a way to kind of check the box. What am I doing in a beneficent manner? What is the patient's autonomy here? Are there issues of justice as we go through these cases? So the other very popular framework is the 4 boxes framework, which was developed by Al Johnson, who came out of UCSF, as well as folks from University of Chicago and University of Washington. And I like to think of it as applied principalism. So there are essentially 4 boxes, which is why it's called 4 boxes. And it's thought to really kind of be most clinically applicable, but it still is based off the 4 principles. So I'll give you a situation. A patient refuses an X-ray or an abdominal X-ray for whatever reason, but it's not clear that she has capacity and there's no surrogate decision maker available right now. So if we're thinking about this with the 4 boxes framework, we would say, okay, well, what is the indication for this X-ray? Is it necessary? What will it show? What are the harms of doing the X-ray? So that combines beneficence and non-maleficence. Patient preferences, well, she doesn't want it, but does she have capacity? Who would be her surrogate decision maker? All of these fit within the patient preferences box. Quality of life, a loaded term, very complicated, but essentially combines beneficence, non-maleficence, and autonomy. And really the questions here are about how do we think about what the patient is articulating their needs and wants are, hence the autonomy playing into this, but what we can do to actually promote their own well-being. And then contextual factors is where justice falls in. So questions of financial issues, religious or spiritual issues, discrimination or bias, which can also go into quality of life for both. So this is the framework that our students in the School of Medicine learn and hopefully remember. The question always comes up, well, which box wins out? Well, the truth is, we can't really say. It largely just depends on what the facts of the case really are and how the individual case really plays out. The other framework that is very relevant is something called casuistry, which is actually based off of Jesuit principles when it was first derived. But the idea here is that casuistry focuses on comparing a current case to paradigm cases with established ethical consensus. And so the reasoning is more by analogy rather than by abstract principle. And so we do this a lot on the ethics consult service. So we'll say, well, what have we historically done in these same situations in the past? Are we being consistent? Are we showing that we are demonstrating consistency and saying according to what are our values? So all of this being said, a lot of this was developed decades ago. I always have the question, well, do these frameworks still apply today? And what are they missing? What more do we have to think about? So I would say that the component that is probably missing is that they're foundational, but not sufficient. They don't necessarily overlay structural inequities in the way that perhaps we are thinking more about now, and relational and cultural values. So autonomy really should be relational autonomy, right? So that is really how an individual patient exercises their choice is in the context of a complex web of family, culture, and community. It's not as simple as this is what I am individually going to do for myself. Most of the patients that we have are making these decisions for what's right for them in the context of a much broader scheme. Justice and how we can apply a health justice framework to the individual patient, I think, is actually very complicated. We are often taught to not think about things like rationing or other components of distributive justice, scarce resources, when you're trying to make a decision for the individual patient in front of you. And yet, I think if we push ourselves hard enough, that's probably always in the back of our mind. Well, we don't have so much ICU space, or well, we need this bed for this reason. And while we don't want to make a decision, it's not something that we forget. But the idea of applying justice more in the forefront of how we think through cases might force us to actually think, well, what is the consequence of me making a decision for this patient, and how can that be extrapolated for others? So if I'm going to say this patient at the end of life should be transitioned to hospice and they don't have a surrogate decision maker, am I using a justice framework to think about, well, am I being fair? And would I say the same thing to a different patient? Am I setting an institutional standard? How can we actually move this forward? So those are elements and ways I think we can continue moving forward. All that being said, this is all, again, foundational. And the most interesting part is to actually go through some cases. So I'm going to go ahead and start with our first case. I'm going to take us through this. We will have time at the end for more distinct questions, but obviously if you have something burning, just let me know. You can feel free to interrupt, or I'll ask Bob and Allison to navigate that. So again, this is a real case. This is on the hospital medicine service. Our patient is an 85-year-old woman with advanced Alzheimer's dementia and is a long-term nursing facility resident. In the last 6 months, she was admitted 5 times for aspiration pneumonia. And although she's not communicative, she's still demonstrating that she does not like being in the hospital. So she probably is mildly disgruntled, doesn't really like when phlebotomy comes and takes a blood draw, can pull at things. It is clear that every time she's admitted, she is not exactly at the baseline that she was at before. So she's probably progressively getting just a little bit worse each time. And efforts to find a surrogate decision maker have been unsuccessful. And certainly for long-term nursing facility residents, the chances that you actually have someone who truly has no surrogate is probably not that common. Most folks probably have someone who has signed them in to live at this nursing facility to begin with. But as we'll talk about later, the prevalence of unrepresented patients is getting much, much, much higher, and something that we need to think about more. But let's assume no rock has been left unturned. We cannot find anybody, and now this patient is going through the conservator process. So I would like for us to play the role of the geriatrician who is taking care of this patient on the outpatient side. So the inpatient hospital medicine team consulted us on ethics and asked, when can we transition her to hospice? Or when can we say, we are just not going to readmit her anymore? She's been readmitted 5 times. We are not making progress. She clearly doesn't like being here. Ethically, can we do that when she doesn't have a surrogate decision maker? So we went, and we are the SNF geriatrician, and of course we bring in the outpatient team when we are thinking about making a change in a patient care plan. And as a SNF geriatrician, you have only met this patient once prior to her most recent hospitalization, but there are other providers that do know her. So I'm going to ask you to just take 30 seconds to put yourself in that position and think about what your first steps are and what ethical issues arise to you. And then of course I'll go through it. And for folks on Zoom, same for you. Okay, so this is how I thought about this case. And I thought this was a really interesting question because I think this comes up a lot, knowing when you as the individual provider need to make a change, or do you just let the natural history of someone's disease process carry itself forward and all of a sudden things suddenly work out and it's not as hard of a decision? So if I were to be purist about this and really do a good job applying this 4 boxes framework, this is how I would think about it. So, and this is what we call an ethical intake and how we think about doing cases on the ethics service. So the medical indications, certainly understanding her prognosis is really important here. She has advanced dementia, is non-communicative, seems to be consuming, but is not yet at the point where she is not eating at all. And obviously this is someone who, as we all know, we're not going to put a feeding tube in this patient with end-stage dementia. And yet knowing her nutrition status might give us a sense of how much time she actually has before we actually have to make a really concrete decision. We also know that it is causing probably my guess is her lung function is not great every time she takes hits through an aspiration process. But it certainly seems that it would be medically appropriate to think about whether the consequences of coming to the hospital actually benefit her, especially if she's not returning back to her baseline. The patient preferences, and this is where it can be very tricky with unrepresented patients. What would the patient have wanted for themselves when they are not at all able to voice this? Of course, ideally, most people have advanced directives. We don't have that. And the other question that I often love to ask folks or ask teams when they say their patient lacks capacity is this irreversible or not? In situations where we can facilitate a patient regaining their autonomy, we should do that. And this can be complicated. The patient has underlying dementia, but they're acutely delirious in the hospital. Do we anticipate that delirium to improve and then they regain capacity, or is this a new baseline? So it is very difficult, but it is our due diligence to always try to offer patients the opportunity to regain their capacity. In this case, this particular patient was very much had very established dementia and even in her nursing facility did not have capacity to make a lot of medical decisions. Quality of life questions. What is a reasonable quality of life for this patient? I think this is actually very complicated and where we can get into a lot of hot water. So the question of the 4 boxes that I think is really important for us is on what grounds can anyone judge someone's quality of someone's quality of life would be undesirable for a patient who cannot express for themselves what they would want. And I think this is what causes a lot of folks a lot of distress in making these types of big decisions. It is often easier to make decisions for a patient's clinical course if it is an emergency and if it's very clear. Either they're very healthy or they're extremely sick, about to be intubated from their aspiration. That is a lot easier to know, okay, intubating this patient is not going to do them that much benefit. But this middle ground of, okay, well, maybe we can just give them antibiotics. 5 days of antibiotics. Okay, all right, well, fine. Okay, they can go back to their baseline. That's what makes it hard. And then it's hard to know, well, do you kick the can down the road, a phrase that I think is not unusual to many of us, or do you say, no, the buck stops here, and we're going to focus on your comfort? And then contextual factors. Are there other interests that might be at play here? What are the SNF's interests in choosing a specific course of the action? Is it easier to transfer someone to the hospital to get the care versus say, okay, we're going to do what we can while we're here. Well, we can put some oxygen on, we can give a little bit of antibiotics, and then religious or spiritual considerations as well. Now, in this particular case, what ended up happening was the outpatient team felt it was reasonable to try to avoid hospitalization if they could by giving antibiotics at the nursing facility, doing what they could at the nursing facility, but did not yet feel like this patient was at a place where they felt like they could truly transition to true hospice or comfort oriented care until her swallowing got so significant that she couldn't actually swallow anything at all. And that is what they felt the most comfortable doing, especially in light that she didn't have any kind of mention of what her preferences were at that specific point. But I think this is a big topic because decision-making for unrepresented patients is what we get called about a lot. And I would say anecdotally, the numbers have been going up. So when we think about the level of incapacitation, the prevalence of incapacity in healthy older adults is estimated to be about 3%, depending on which study you look at, around 3%. But then it's much higher in certain populations. So inpatients on the medical ward, the prevalence goes up to about 25%. Those with Alzheimer's disease, and considering those at all different stages, the prevalence is up to 54%. And then the highest rate was seen around about 68% in those with learning disabilities. So it's pretty high. And so knowing how to assess capacity is certainly just as important for us as clinicians as knowing how to actually treat an aspiration pneumonia. Then we think about the lack of representation. Okay, well, a lot of folks don't have advanced directives, don't have appointed surrogates. And if we take a lot of the data all together, we're seeing something around maybe 3 to 5% of the general adult population, and adults 65 and up, closer to 15% maybe don't have a surrogate decision maker or are unrepresented. And by unrepresented, it's not, I should clarify, it's not just that they haven't appointed someone, it's that they truly do not have someone who could speak for them. So no family, no close friend, et cetera. And then in those with dementia or serious mental illness, up to 30%. And this is going up. And speculation about why this is going up, people are living longer. We're a little bit more societally fragmented. So that people aren't living in as much close community as we used to. Those are just some of the reasons that have come up as to why this is more relevant. So what does this mean for how we should practice? So I can tell you some new things in the legal landscape. The idea that having just gone to the American Society of Bioethics conference last week, there was a lot of discussion around this. And there definitely seems to be a national trend towards thinking that it's very rare for someone to not have anybody to speak for themselves, even though the prevalence is going up. And there are new legal cases around the country that suggest a trend towards ensuring that we find surrogates. So I believe in Michigan, they're trying to more formalize a surrogate hierarchy in decision-making. Remember that in California, there is no order of proxy, and that is very different from many other parts of the country where there is a very set order of proxy. In North Dakota, there is a case where they're expanding default surrogate to add an interdisciplinary team as a potential surrogate, which I think is actually fantastic. And now a California statute is also trying to make things just a little bit more straightforward for us. So what this statute, AB 2338, it actually provides a process for patients with capacity to verbally designate a surrogate decision maker for a set period of time, and that can be put into the EHR, even if it's that's different from the person that is set in the advanced directive. So let's say that that designated surrogate in the advanced directive is out of town or something. We all know that we can take someone's word, and that is what stands. But this actually formalizes it and codifies it a little bit more. And then the same statute is trying to articulate where you can go to find a surrogate. And they don't rank these folks: spouse, adult child, adult parent, adult sibling, adult grandchild, adult relative, or close personal friend. Doesn't matter which order. This is not a rank order, but it explicitly states what the options are. So all in all, more to come about how this is going to play out. But I think what we're going to see more of is more distinction and more necessity to be very, very clear that someone truly does not have a surrogate, and be clear who is actually making decisions for our patients. And hopefully, ideally, that helps us a little bit in this quagmire of like, well, who is it, me? Is it you? Who consented for that procedure 2 years ago when they still had dementia? These are all questions that keep coming up for us clinically. Okay. Moving on to case 2. This is another case from the hospital medicine service, including that involves some of our well-known consultants. So this is a 71-year-old woman with advanced Parkinson's who was admitted with a traumatic subarachnoid hematoma after a fall. So her course was complicated by multiple PA arrests, including one that was possibly related to a medication error, leaving her in a near vegetative state. And then approximately 2 weeks into the hospitalization after treatment for recurrent aspiration pneumonia, her renal function began to decline, and she developed massive volume overload. So there were multiple family meetings, and the family wants dialysis. Like, we want it, do it. Okay. I'm going to ask you to turn to your neighbor if you're here in the audience. Think to yourself if you're out in the Zoom world. What do you do? Do you start dialysis? And you've tried really hard to convince the family. So the answer can't be go talk again. That's not a viable choice. So, okay, so do we offer hemodialysis? And if so, for how long? So I'm adding that extra piece there. So the hospital medicine physician in me is screaming, don't do it. It's going to be so hard to take off. It's not going to do anything. There can be all these complications. We learned, it was beat into our heads, don't do it, don't do it. But now I'm not here with my hospital medicine hat on, with my ethics hat on. It's a little bit more complicated, right? So in thinking about these components, as I said, there are lots of potential harms to going down this road. Are there benefits? Well, maybe it will help her volume overload. Maybe it can be very temporary, and we can get her out of an acute situation, and she can go back to her baseline level of functioning, which it sounds like, at least from what we know from the what I've presented to you, that perhaps that is acceptable right now. Because I'm not saying, and it may not be that the family is expecting that she walk out of the hospital, right? But it may be that we get her back to the way she was 2 weeks ago, before her kidneys got worse. Is that okay? maybe that is okay. Why would it not be okay? And then that gets into autonomy. Well, who decides if it's okay? Is it me? Because I think dialysis can have bad outcomes. We also know dialysis can have great outcomes, right? I mean, there's a reason why it was developed. And is it the patient's right to know that, well, there is a procedure, there is an intervention that can remove all this volume? Who are you to tell me that I cannot have that done? I'm being a little bit inflammatory intentionally because I want to back us against a wall a little bit. So, all right. And then resource allocation, of course, is something that we think about. This patient has been here in the hospital. We don't know from the information we have where this patient's trajectory is. Are we en route to going to an LTAC after this, or home, or where this patient is? But it's something to think about what this means for her overall hospitalizations and the complications that can come from being in the hospital. Now, time trials, I think, are very fascinating. We do this all the time. Well, we can try. Why don't we try dialysis? 5 days, 10 days? How long is long enough? We can try antibiotics for this period of time. We can try transfusions. 2 units, let's see what happens. 2 weeks, let's see what happens. So there's a lot of gray and a lot of nebulousness, but this is something that we do not infrequently. And then the other question, which is also a little, needling, who offers the hemodialysis? The hospital medicine attending says, okay, let's try it. Let me call whoever is on renal consults and say we need dialysis. Or is it our nephrologist who decides whether they should offer it or not? We've discussed aspects of this case before, and I think, as we all know, there are varying practices both among our general medicine teams, but also among our consultants. And some may offer, some may not. Some may say, okay, we can do this. Some will say, absolutely not. And patients who have been in the hospital for long enough will also know that you just wait a few days, someone else will come on. And there might be a difference of opinion. And that is also a host of complication as well, because it is very hard to ensure that there is consistency across the board. And as we think about how the system can help in these situations, certainly our systems leaders can help with this as well. Okay, so it was started in consultation with nephrology and ethics. So ethics was involved. Multiple family meetings, multiple teams, the patient's PCP, hemodialysis was started with the stipulation that this would be a temporary measure to allow the family to find alternative care or transfer to another medical center. And I'll get into that process as well. But that was the stipulation. Okay, you can go and transfer. We'll start it for this set period of time. But despite the hemodialysis, the patient became hemodynamically unstable from a probable pulmonary hemorrhage and was transferred to the ICU, requiring max ventilatory support. And now our ICU physicians are left with the same ethical quandaries that we had this whole time, and now with an additional intervention of ventilation. Okay, so how practical is it to get a second opinion or transfer? I think this is a really important and interesting question. And if you haven't seen already, UCSF has a website for second opinions. You just UCSF second opinion, you can put in all your information and you can actually go through a formal process of getting a second opinion from a UCSF physician. So this is probably more geared towards folks who are outside the institution who want a second opinion from UCSF directly versus within our institution. But I would say there's actually been a rise in requesting second opinions or potentially transferring through rising polarization, eroding trust, and a shift in power. And all of this has led to actually increased use of second opinions. Most of the data around this is in the outpatient oncology literature. There's very little actually when it comes to transferring of institutions. Although I think we can all imagine how much inequity there is when we think about who can feasibly transfer to another institution, who has the resources, who has the connections, who can actually make this happen is certainly very inequitable. There was also a study I read recently that second opinion, request for a second opinion is also associated with social media use, which is also that's not that bizarre, I think. You see enough on Instagram or whatever else people are using these days to say, oh, my loved one got this care at this institution, the other one got this care at a different one. Now, there is also this idea of duty to transfer. Do we have a duty to actually facilitate a patient's transfer to another institution if our institutional culture or institutional protocol necessitates a certain course of action. And some states have actually put this into their own statutes, but they have put it in as a time-limited experience. So Delaware, for example, says there is a duty to transfer, and the duty is time-limited for 15 days. So if within 15 days it doesn't happen, we've done our due diligence, it's not going to happen. Utah, 10 days. There isn't anything like this, I believe, in the state of California, though correct me if there are any legal scholars out there. And then we'll get into our own unilateral policy a little bit later, where this is a little bit more explicit. And now begins the question of who decides whether or when to stop life-sustaining intervention. So now we have our patient now who is on dialysis in the unit, now on max ventilatory support. And really the question is, when do we stop? And who decides that? Is it the family, because we're valuing autonomy? Is it the ICU attending? Is it the renal attending that says, okay, well, now we're just going to stop hemodialysis at this point? In general, public perception suggests that patients should be involved in the decision-making about their health, but there's really limited data on unilateral decisions per se. And probably at UCSF, only a couple cases of a year actually result in a unilateral withdrawal. Interestingly, most states have statutes that support unilateral decision-making. So 98% of state statutes explicitly support unilateral clinician decision-making. And the reasons include medical and reasons of conscience. So I'm not gonna touch the conscience aspect here, but that is there in statute. Medical reasons that they have voiced are medical ineffectiveness, contrary to medical standards, medically inappropriate, and maybe only 10% actually use the term futility. The California probate law uses the term medical ineffectiveness. And if you consult us and we are consulted on a unilateral question, we use the term medical ineffectiveness to be the most aligned with the California probate code. And that's actually what we encourage teams to use too, even with patients. Futility is a really loaded word, and we can get into all sorts of conversations about qualitative futility and quantitative futility, et cetera, et cetera. But so medically ineffective, I think, paints a picture to our patients as to where we are coming from with our choice. So the unilateral withdrawal policy at UCSF, we have a policy for withdrawing life-sustaining intervention and for code status, so changing code status to DNR and DNI. And what our policy says, and what you may have heard from us in consultation before, is you are under no ethical obligation to offer medically ineffective care as a clinician or a provider. And if you're at the point where the family is requesting medically ineffective care, you are under no ethical obligation to go ahead and do that. You can set a time with the family as to when you are going to remove a ventilator, stop hemodialysis, change a code status. We offer to the family an option to transfer to another institution, knowing that that process can be very challenging for many people. An opportunity to speak with us on ethics. We like to meet separately with families, not with teams, because we want to be an impartial body to families. And then we document all of this in the chart. And if you call risk management, they'll tell you number one thing you can do is to document, just document everything. So that is our unilateral policy. Like I mentioned, very rarely are we at the point where we're truly acting unilaterally at the very end of all of this whole process. And in this particular patient case, hemodialysis was stopped at the end of the specified period of time. So great consistency, sticking to what you said is very, very important. And the patient ended up dying 2 days later. So this was a very interesting case in light of how many different teams were involved, how complex the decision-making was, but also this idea of, should we start something that is hard to stop? And also, who is responsible for actually starting that intervention? Okay, last case. So this was a case that I was consulted on probably around 7 years ago at this point. And I still think about it. So it's a 35-year-old man, presents on transfer from an outside hospital for an orthopedic procedure. He has a PICC line in place for access and was found to have MSSA bacteremia. Still don't really know when the PICC line was placed, how the bacteria, was it before, was it after? There's some nebulousness about the line and how the bacteremia developed. But lo and behold, he is here with a PICC line, with MSSA bacteremia, and with persistently positive blood cultures, osteomyelitis, intermittent fevers. So an indication that perhaps that line should be removed. He also has a long-standing history of intravenous drug use, to the point where now, confounding all of this, is a lot of chart lore, both from the outside hospital and from what's being seen on the floor, concerns about visitors, concerns about a lot of behavior around the use of opiate pain medications, concerns about a degree of quote unquote caginess. And so that's there in the lore. Clearly, this patient has also experienced a lot of trauma in the hospitalized setting, a lot of stigma in the context of intravenous drug use, and has been very inconsistent with care both in the inpatient and outpatient side. So we can play the persona of multiple people who are involved in this case. The infectious disease consultant who's saying, got to get that line out. Antibiotic lock therapy, try not to do that. We have clear evidence that this is a persistent infection. We got to get the line out. You're the medicine consult team also navigating this, also saying you got to get the line out. Patient refuses. Absolutely not. Do not touch this line. I don't want anyone poking me again. This is my line. I get it. I get that there are consequences. I get that I can die. I want my line. Do not touch me. Oh, I'm done having this conversation. That's how that conversation goes. That's where you're at. So what do? You can all discuss. You cannot convince the patient. You cannot convince the patient. You've tried it. You've done it. Code care is there. Everybody is there. You cannot convince the patient. Here's where we're at. Do we remove the line? I know this disadvantages a little bit the folks on Zoom because you can't see this, but because I can't not ask this question. Who wants to remove the line? Raise your hand. Who wants to remove the line? Well, okay, who would, sorry, yes, good point. We all want to remove the line, yes, no kidding. Who would recommend removing the line? So yeah, how would we do this? We would, so for those on Zoom, the question is, how would we actually make this happen? Yeah, do you hold down the patient? Great point, Dr. Panelette. Do you hold down the patient? Do you chemically sedate them? And do you take that line out? And when he wakes up, you're like, where is my line? You told me you did this against my will. I get that you're treating my MSSA bacteremia. You did this against my will. Who wants to do that? Oh, now no one wants to do that. We had a few hands before, but now, okay. Okay, who says, this hard, not ideal. We'll find a way. We will find a way. Just keep that line in. Okay, so for folks on Zoom who couldn't see, we had a few more hands that said keep their line in. I think a lot of us are struggling. I struggled. This was really hard. So I said, keep the line in. The patient has capacity. They have the capacity to make bad decisions. They're making a bad decision. We have explained all the risks, explained the benefits, they have capacity to make this decision, cannot probably keep the line in. So this was about 5 p.m. I got a call from the ortho attending the next day. The line was kept in. It turns out at night, there were some pill fragments found. The patient injected into the line, developed an air embolism, and died in the hospital. Shocking. So, still like a little bit mildly tachycardic even presenting this case because this was a horrible call to receive the next day. Because I said, keep the line in. That's why they called me. I said, keep the line in. And now this patient is dead. Right. I still think about this case. It is extremely distressing to me. The ortho attending was also a colleague of mine who I had worked with in different circumstances. And it's not my name on the hospital record. It was this attending's, right? So what liability does that attending have? And of course I did what I always do. I freaked out. I found the people in the 6-long attending room, like, oh, what happened? Found other people in the Moffalong attending room. Oh, what happened? Called Andy Josephson. Andy, what did I do? And Andy and Wade, who is here, are two of our other ethics consultants and mentors of mine. So of course I'm going to call someone who has done this for longer than me. I'm like, how did I screw up? We all thought, okay, it was that the patient had capacity. Patient had capacity. And I think the question still comes up as, does the outcome justify the ethical approach in decision making? So yeah, the patient had capacity, but he also had a very severe addiction to a substance that was probably also altering his brain chemistry. And everyone I talk to in the addiction sphere will say, well, this is a little different. We're not saying people with an addiction have lack of capacity. And there is still not that much research out there to say, well, they're very dependent on something that is demonstrating harm. And still, this is someone who, if we had held him down, chemically sedated him, taken the line out, could very well be alive today. Maybe would have gotten treatment. Maybe would have gotten a cure. The other alternative could also have been, there's a horrible procedural complication in removing the line. Now, not only is there a complication, but you've also done that against their will, which is a whole host of badness, I will say, for lack of a better term. So this leads me to discussion on moral distress and moral injury. Now, there are a lot of different definitions of moral distress. I used to have a different one that talked a little bit about not feeling like you could act according to your values in the context of the system. But this one, I think, gets to how I felt after this case. So I'm just going to read it aloud to you. Distress that arises because personal experience disrupts or threatens A, one's sense of the goodness of oneself, of others, of institutions, or what are understood to be higher powers, or B, one's beliefs or intuitions about right and wrong, good or evil. A little bit extreme wording, but I think it gets at like, well, did I do the right thing? And what is actually the right thing? And when that distress becomes sufficiently persistent, it would constitute moral injury. So when you have repeated hits, it would become moral injury. And we don't always necessarily reset to our baseline after each of these different hits. It is always very helpful to discuss these cases with colleagues, with friends, in formal situations such as Schwartz rounds or other kinds of M&M proceedings if the environment is conducive to a healthy discussion. That's not always true. We're lucky in the Department of Medicine that we have a culture around that. But all of this is to say, ethics is really hard. They're very tough. If you are finding distress around it, welcome. We all are, even those of us who do it all the time. Frameworks can help us mitigate moral distress, and commiseration and discussion is key. So I just wanted to round out this talk with a few acknowledgements. First, to UCSF Bioethics and the Medical Ethics Committee. So UCSF Bioethics has a long history of excellence in the realm of bioethics, dating back from Al Johnson, Bernie Lowe, who many of us read in medical school. It is currently headed by Winston Chong in the Department of Neurology. There are some amazing people doing phenomenal research, a host of different projects and ideas. So if you're interested in at all ethics on a larger scale, go to the website, sign up for the listserv. They do a monthly journal club, which is really great. But this is a great resource. So as Bob mentioned, the Medical Ethics Committee is something that every hospital has to have, and luckily we have. We are multidisciplinary, interprofessional. We once a month. This has been probably one of the most rewarding experiences of my career thus far. And I think for the most part, we agree on many things, but it's even better when we don't agree, because then we actually have really great conversations. We just had a case discussion last couple weeks on a pediatric case where we were split as to whether we should recommend calling Child Protective Services in this situation or not. And it was a phenomenal discussion and really important. But I am very grateful for all of the folks on the Medical Ethics Committee for their discussion and their engagement, and for letting me lead the charge. All of you, folks whose cases I presented today, some of you are in this room. Thank you for allowing me to share it, and thanks for calling us, letting us be engaged. And I know sometimes calling us can be really frustrating. We don't always tell you what to do. We don't want to. We don't want to tell you what to do. We want to say, well, this is the ethical course of action. This sounds a little unethical, but you are the clinician, and we give you decision-making power. And that is the way ethics is set up at this institution. And most of the time, folks are calling us not because they don't know the ethics, but because we're really distressed about what it means and how to execute it. And so we understand that. So we appreciate allowing us to be part of that. And many thanks again to Wade Smith, who has mentored me through all of this. And of course to Andy Josephson, who opened so many doors for me and has been a mentor and sponsor in ethics throughout my time thus far. And I couldn't really do anything without him. So thank you.
Thank you, Sirisha. That was terrific and thought-provoking. Surgeons sort of routinely say, I'm not doing this surgery. And we kind of accept that generally. Then you have, it seems like there's almost a hierarchy of people's ability and our acceptance of their ability to say, no, I'm not doing that, with surgeons sort of being at the top of that hierarchy, nephrologists and other medical proceduralists sort of one step down, and folks like us, you know, saying we're not going to give antibiotics sort of lower down. Is there anything codified either in the ethics literature or in the law that sort of allows for that kind of hierarchy? Why couldn't the nephrologist say, I'm not doing dialysis, or we might push back against that, whereas a surgeon, we sort of say, well, you're the one who does the surgery. And I think there's a related issue, which is sort of what is the role of the autonomy of the provider? Like, does the provider have any agency or any rights in any of this?
Yeah,
I think
yeah, that's a great question, and definitely something that I've personally been frustrated by as a hospitalist. Oh, why can't I just say no? You know, I think some of it comes to the ethos of the ethics in those fields. So if you think about let's say a patient doesn't have capacity and you want to do a procedure, in certain situations, in a surgical situation, that could be viewed as assault or battery. So some of it is just how that, and the way surgeons describe it is, I am doing something to someone that has the potential for very adverse harm. And I think the level of harm in surgery is, for many cases, for the vast majority of cases, probably a little bit higher. Of course, we can debate the nuances, debating which medication we give, but I think some of it is the ethos, some of it is the level of harm. I think it's hard to not acknowledge that the outcome metrics may play a role there. You know, you want to ensure surgeons are going to do a surgery if they know the outcome is going to be positive. If you know the outcome is not going to be positive, that can totally affect their whole practice. Well, I don't think that's the real thing that is driving a lot of hesitation to do a surgery. It is still there in the same way that the number of beds we have in the hospital is something that we get reminded about all the time. So I think it's multifactorial. And yes, there is a gradation. I don't know of anything overtly mentioned in the law or statute or code of ethics per se, but I think a lot of it stems from our own ethos around it.
We open it up. Folks have questions or comments? Thank you, Allison. I'll throw one more out while we're waiting. Oh, we have one. Go for it. Say who you are.
Hi, I'm Ria. I'm a third-year medical student on medicine right now. And I have a question about the third case. I know a lot of times for our patients with substance use disorders, we debate a lot about whether to use a PICC or not for concern of misuse of the PICC line. So I was wondering, in this case, was that like a discussion that had been had prior to then what ended up being the situation?
Yeah, I think in this particular case, the patient came in on transfer already with a PICC line. And so how that discussion was had is a little unclear. Granted, in a hospital setting, we can theoretically monitor more. And really only nurses are supposed to be handling the PICC line. Of course, the outcome of this case says, well, is that always true? I mean, it wasn't true in this case. So I mean, I think our hesitation is certainly very clear if the patient was about to discharge or on the outpatient side. Inpatient, when it's access issues, when it's a matter of delivering the medication, I think it's a lot hairier, and we probably allow for our patients to have access in the hospital. But in this case, the patient came in on it.
In that case, sounds like you've ruminated about this over 7 years. If that patient came in today, what would you do differently?
Yeah, this goes back to the question, well, I know the outcome. Would that have changed how I do it? And we talked about it, and the the patient had capacity. It's really hard for me to let go of that. That's a lot of what, or even our ethics consultations goes back to. And there's some logistical things I would have done differently. I would have maybe talked through it more with the ortho attending up front, had a game plan. I think after this case and several others, there were some more institutional policies that came up about monitoring it. But from the ethics standpoint, yeah, the patient had capacity, Bob. It's really hard to get over that.
Yeah, no, I sort of landed in the same place. And you talk about assault or battery, whichever one is that you are assaulting the patient to do something, and the patient has, if you truly believe the patient has capacity. And the counterfactual, of course, is you took it out and then he sues you for having assaulted him. Steve.
Yeah, Steve Panela. Thank you, Sirisha. That was great. I guess two comments. One, just as a practical matter, I mean, the thought of either once trying to sedate this patient against his will or holding him down and taking out a PICC line, which is not simple to do and not simple to not have a complication. I think it to imagine that you would violate someone's personal freedom in a way that you would do that to them. So I think as a practical matter, which I think ethics often falls in that way, it's just hard to see it. So that's one. Number two, sure, if you had taken out that line, he would not have been able to use it to inject drugs. But that's not the reason you were taking out the line. You were taking out the line because you thought he had a complication, an infectious complication. And so, I think that matters here ethically because the reason to take it out and the reason he was refusing are important here. And you wouldn't walk around and say, well, I'm taking out this line because you might shoot in it. And if you do that, you might get an air embolus and die. So I have to take this line out. Because if he didn't have, a line infection and bacteremia, you wouldn't take out the line. He could still shoot and still die. So if there are reasons to monitor people who use injection drugs and have a central line, and we need to monitor them in some other way, we need to do that. But I think as far as the ethics of this case, I think you made the exact right decision here. I can see how it feels terrible, but I think you did the right thing.
Thank you. And for what it's worth, the opening door for me in ethics was actually a conversation I had with Steve Panelat on year 2 as attending, who said, you seem interested in this stuff. Go talk to Andy. So thank you, Steve.
Just a follow-up, Brian Schwartz, infectious diseases. Follow-up question. What if the patient had been witnessed to do this, did not die? How does that change? But in the hospital, they're seen injecting. Does that change the way you'd approach?
I mean, I think it's an interesting question because, again, if we go back to, well, we need to get this line out because he has a persistent infection. Well, I'd still say, yeah, you need to get the line out. And then I would again say, you really need to get the line out because you can have an adverse outcome. Again, it goes back to the patient had capacity to make really, really, really bad decisions. Now, risk management may have a different opinion here because they will say, well, now this is a liability issue. And I think we actually take it a lot more seriously now than before. And there may be other processes. But again, it's hard to imagine what the process would be in actually removing this line. And that would probably cause a host of different issues.
I think Rita was next.
Just a comment, Rita Redford, cardiology. And going back to the earlier cases, a lot of it also is how we frame things to patients, like your example of hemodialysis. I mean, you have to assume the family thought hemodialysis would turn things around when the overwhelming issue was that she was in a vegetative state and was unlikely to recover. So we talk more, this would prolong her dying and prolong the suffering, which I truly believe that would have. It's very different than thinking, oh, we're not treating and not offering something that could make a difference, because people don't want to prolong suffering.
But some people do, or some people would. Clearly, the family judged her quality of life to be sufficient, acceptable, that status quo was something that they wanted to preserve, I guess.
Yeah, and it's not uncommon for us. these examples obviously are with adults, but in the pediatric world, there's a whole other dimension of what suffering is. And if you're the parent of a child, parent knows best, right? Parent can decide what suffering is and what's not, and how does this other hospital person know what this actually means? And I think the suffering and what that means can feel so different for patients, even in the ICU. It's not uncommon for a family to say, "What do you mean they're suffering? You are on 4 different various sedative medications. You can't tell me they're suffering. Like, they're totally fine." Yeah. It's really hard. And I think probably society, if you look at what's happening in society at large, whether it's conscious objection, school choice, what have you, we are moving much more towards a realm of autonomy at all costs. And I think that's something important that we have to think about in light of all the different challenges we have in healthcare.
Yeah, we need to quip it. I'll just say at all costs is an important, you meant that metaphorically, but you talk about the cost of some of these things that of course is not borne by the patient or the family. Generally, it's borne by the collective through insurance. And so the idea that anyone can choose anything about anything because they want it, and the costs are not theirs to bear is just almost an impossible conundrum. So we need to quit because of time. I think Sirisha can hang around and chat, but thank you so much.